Okay.
Professor Punky, is this being recorded?
Yep, I just hit record. You got it.
Awesome.
Yep. Thank you. So, what did we say? So we've got the heart. This is typically how I draw a heart, even though it's not anatomically correct. We all recognize it as a heart. And then I'm going to have upper chambers and lower chambers, and I'll always have a right side and a left side, right? The upper chambers are called atria, both of them. There's a right and a left. And there's also ventricles, right and left. Okay, are we all good so far? There's a septum that runs this way, up and down, separating the right from the left. And there's also border that separates the up from the down. And then you'll have your tricuspid valve and your mitral valve. Okay, tricuspid is on the right. Mitral is on the left. Okay, so far so good. Let me see where I'm going with my PowerPoint because I don't want to get too far off track. So the right side of the heart is the receiving part, okay? So this receives blood, and it's always unoxygenated. Okay, the right side. And it comes from the vena cava, right? And that all comes from all the veins. So the veins bring all the unoxygenated blood back into the right atria. Okay, then what happens is it'll come into this atrial chamber, and as it fills, I always think of the heart chambers almost as rooms, like in a house. And the valve is like a door. So if you are having a house party and everyone's coming in the front door, all of a sudden that living room is going to start to fill up with people. Or in this case, that atrium is going to, or atria is going to fill up with blood. And what happens is when this door is shut, there starts to become a pressure. People are going to start getting kind of pushed against the walls, and someone's going to look for the door to open. If this pressure in the atria overcomes the ventricular pressure of an empty ventricle down here, it will pop open that valve. So valves open and close by pressure changes. That's super important to know, especially as we look at like valve disorders down the road. So valves open and close because of pressure changes. Now, as this blood goes down into the ventricle, it'll start filling up down here. And this pressure will eventually overcome this pressure, and it will shut that tricuspid valve. Okay? So pressure changes, filling. Now the same thing happens in the left, but the blood comes back from the lungs. Okay? And it dumps in here. Same thing. It fills until the pressure overcomes the ventricle. It opens the mitral valve, and then the ventricular pressure fills until it has enough pressure to snap the mitral valve closed again. Okay, so that's kind of the basics of how the heart is set up. Very superficial though. Not going to teach you any more than you need to know. There's also some great vessels. The aorta branches off of the left ventricle, and the pulmonary arteries branch off of the right ventricle. So this is not anatomically correct, but I like to draw it this way. Your aorta comes off of the left ventricle, and it carries oxygenated blood to the body, right? All the way to the toes, the eyeballs, the belly, whatever you need. The right ventricle pumps out to those lungs, unoxygenated, to pick up oxygen in the lungs, okay? And then it actually does that and comes back in oxygenated. If you need to, it might be good to review your A&P about the cardiac system, because I can't teach you everything. I'm just going to give you enough to get you by, okay? Let's see what's next. So in this diagram, you can see that the blood is in the receiving chambers. So it's coming through the vena cava into the right atrium. It's also coming into the left atrium from the lungs. Okay, and as that fills, it's going to create that pressure and it's going to start to open those valves, and then the ventricles will fill. The next step then is the ventricles fill enough to snap those valves back closed and also snap open the outer doors of the heart, which are the pulmonary artery and the aortic, or the pulmonary valve leading to the aortic pulmonary artery, and the aortic valve leading to the aorta, so that the blood actually leaves the heart out of these two, goes to the lungs and goes to the body. Okay, that's kind of a down and dirty A&P lesson. I'm going to stop and I want to see your faces to make sure that nobody's too lost or looking like a carp with their mouth hanging open. Are we good? Looking good? Okay, let's keep going. So we need to learn too about the heart wall a little bit. So there's 3 layers to the heart, and I want to show you that. Make sure we're still spotlighted. So this whole entire outer wall of the heart has 3 layers to it. Okay, there is a epicardial, which is the outside. And so that's like the encasement of the heart. If you're looking at the heart, see, I've got this little heart right here. So all of this heart is wrapped in epicardial layer. Okay, it's fibrous and it keeps the heart together. The middle is the myocardial, or myocardium, and that's the muscle that actually does the contracting. So we have to keep this. This is the most important part of the layers, because this is the muscle that makes the contractions happen and maintains a cardiac output. Then you have an endocardium, which is the inner lining, like in here. That's just the inner side of the wall of the ventricles and the atrium. Okay, so there's 3 layers. Plus, around this heart, there's also a pericardial sac, which doesn't contract or expand, but it just holds, it protects the heart, and there's fluid in there that helps cushion the heart and protect it. Okay, this should not be new if you've made it through 140. We already talked about the 4 valves, but we can kind of just talk about it word-wise and not go back to the picture. The tricuspid valve is between the right atrium and the right ventricle. The mitral valve is the same, but on the left side. The aortic valve is the valve between the left ventricle and the aorta. And then the pulmonic valve is between the right ventricle and the pulmonic artery or pulmonary artery. Okay, the 4 valves, 4 chambers, easy, 3 layers. Okay. Now let's talk about cardiac cycle. When we speak of a cardiac cycle, that means one cycle is the filling and the emptying of the heart. So one cardiac cycle sounds like lub-dub when you're listening to your own heart, and it means it's filling and it is emptying, all in that one shot, and that's one beat. Okay. Diastole is the relaxation part of that cycle, and it's when the ventricles are at rest and they're filling. Okay, so that's important to know. Diastole is when the ventricles fill. Let's see, I think you know all that. I think you still know all that. Systole then is during the contraction itself. So you'll have a diastole and a systole, all part of one cycle. Systole is when the ventricles contract and expel most of the blood out of the heart into either the lungs or the body. Okay, and all of this happens because of those pressure changes that occur in each of the chambers. Now, we understand the plumbing, right? But here's the thing. The plumbing doesn't happen on its own. It's not like our toilets and our sinks. It has to have electricity that stimulates contraction. So without the right electricity, we're going to have a heart that doesn't pump. So the electricity in a heart is called the conduction system, the cardiac conduction system, because electricity is conducted through that muscle. Okay, so I'm going to stop sharing there and go back to my little diagram, but it's so messy, we're going to start over. Okay. So we've got this beautiful heart that's working well. If it's working well, we've got an SA node up here, which stands for sinoatrial. That node is actually a pacemaker. Okay, and that is your heart's best pacemaker. This is the one that fires and creates the impulse for every beat that you have if you're healthy. Okay, so what happens is it will fire and then it will follow the conduction path down through the heart, and as it follows through that path, it will create contraction because it's like impulse going through muscle. So of course your atria contract first and then your ventricles contract second. That's how it's timed because of the way the electricity is running through that muscle. So it starts up here and it winds down. It goes through another juncture called the AV node, and then it goes through other little ones called either bundle branches or Purkinjes. This shouldn't be new to you. And then it wraps around the back of the heart, which I can't draw on a 2D piece of paper, the back of the heart, but it wraps around and then it goes back up here to tell the SA node, okay, it's time to do it again. Okay, so this happens when the SA node is firing correctly. It happens between 60 and 100 beats per minute. Okay, so all of us have healthy hearts, and when our heart rate is 80, it means our SA node is clicking away at 80. Okay. Now, let's say some bad examples. Maybe this guy's got some bad health. Let's say he throws an infarct to this part of his heart. He can actually wipe out his SA node and kill the tissue around it. Now, if our bodies weren't created so great with backup systems, we would die if we didn't have an SA node because that's our pacemaker. But we have backup pacemakers. The AV node is the next pacemaker, and it's a backup. It's not the first choice for sure. When this AV node senses there's no electricity coming through it from up above, it will kick in and it looks around and says, oh crap, I guess I have to be the one. Okay, it doesn't want to. It wants to just kind of be the person that it goes through, but now it has to be the generator. When the AV node is the true pacemaker, it can only generate a heart rate of 40 to 60 beats per minute. So you can see where this is not optimal. It's hard to keep your tissues perfused at that slower rate. Okay. Now, let's just say he's had the worst day in the world and his MI took out all of this. Now what? Now does he die because he doesn't have a pacemaker? No, actually, the Purkinje fibers and bundle branches have little tiny pacemakers that can take over if there isn't a current coming through. Unfortunately, these Purkinjes can only generate a beat of 20 to 40, maybe even 30 beats per minute. This is suboptimal. You will die eventually. This might keep you alive till you get to the hospital, but you're going to need a pacemaker or something inserted so that you can maintain a better heart rate that sustains a better cardiac output. Okay. So that's the conduction system, and I know that we've got like 3 slides on it, but I just told you everything you need to know that's on those 3 slides. Questions about the conduction system? Okay.
Where does the electricity come from, like, in those nodes? Like, how does the node develop electricity?
That's interesting. You know, it's kind of above our pay grade to know that, to be honest, but it has to do with the sodium pump and the potassium pump and the way that that whole tissue works with electrolytes and energy, ATP. It's more complicated than anything I'm going to be able to explain to you today, but it is fascinating to think about that. Like, where does that electricity come from? It's a good point.
Yeah.
Yep. Yep.
Well, thank you.
You're welcome. Anybody else have any questions about anything so far? Okay, then we're going to keep moving. So now if we just had the heart as a pump and nothing else, we would die, because the heart isn't there just to pump for itself, it has to pump blood to the tissue. So the other side of a cardiac assessment is the vessels, the vascular system. The vascular system is made up of arteries and capillaries and veins and venules. And I want to stop because I am sorry, I'm just a big drawer. When you have vascular system, you start out with an artery, okay, that comes from the heart, and then it gets smaller and it branches into an arterial, okay, and then they branch out smaller and smaller. Now, this delivers oxygen, right, to the tissues. But what happens is that's not the only thing that your vascular system does. You have venules and veins, okay? So just like arterioles are smaller arteries, venules are smaller veins. So what happens practically is when a little red blood cell comes down this artery and it starts delivering oxygen to your toes, okay, that gas exchange happens here, and this is the capillary. The capillary bed has arterioles and venules, okay? So it kind of does a dual purpose thing. The oxygen is jumping off and being delivered to the cells, but like the CO2 and the other waste is jumping onto the venules so that the waste can be carried back out, okay? So everyone understand, the capillary bed is made up of both. And all that gas exchange happens between, you know, your cells of your toes or your intestines, whatever, and the capillary bed. Okay? So the thing about arteries is the arteries are coming off of the aorta, and the aorta is coming off of the left ventricle. Well, what kind of pressure does it take to get the valve open of a left ventricle to get out into the aorta? Usually a normal blood pressure of 120/80, right? I mean, that's what a blood pressure is. It's how much pressure it takes to get that aortic valve open. So these arteries have a high pressure system in it, you know, high pressure, a hard pump to get that blood all the way to their toes. So these arteries are much tougher, and they're more resilient, and they're more elastic than the veins. The veins, it just passively comes back to the heart. It doesn't have this hard pump behind it. It just naturally comes back. So I just wanted to make sure you understood that the arteries are much tougher and much more elastic. Yep, I just told you that. Okay, so I'm going to bop out again because I really want to make sure that any questions are answered. There. Tell me what you're thinking.
I have a question,
Okay.
Professor Punky. Well, so will the lecture video be posted today?
Yeah. Now,
Okay.
I don't know if Professor Moore told you, but it takes a long time to download from Zoom, and then it takes quite a while to upload to YouTube. It usually takes a couple hours for the whole process, but absolutely, absolutely.
Okay.
Yep.
That was a lot. So we plan to
Okay, so my connection just bugged out the minute you asked that second question. So what was it?
Oh, that's okay. I just wanted to make sure that it would be posted like in enough time for us to go back and review your pictures.
Oh, absolutely. Absolutely.
Thank
I don't
you.
like things on my to-do list, so I will definitely get that done, unless it slips my mind completely, but I'm hoping that it won't. So if you don't see it by bedtime, email me and I will make sure that I put it up, but I try really hard to be responsive with that because you need that. You need to watch it a couple times. As far as the A&P, what questions or thoughts do you have? Is this the way you learned it in 140 or 206?
I mean, I don't know if this is bad or not, but like some of these, like the bundle branches or the Purkinje's, I don't remember learning about those. And I just got out of bio.
Okay, Purkinje's, that's all in the ventricles. So yeah, Yeah, I don't know. You learned it now though, so that's good.
I was wondering, I feel like so far we haven't been really on like
Danielle, I'm so sorry, but my internet just glitched again. Can you repeat that?
yeah, I said I feel like so far we haven't been like really quizzed on anatomy. Are we going to be quizzed on it now, or is it just to help us understand?
It helps you understand, but you know, anything we teach is fair game, unfortunately. So there may be a couple anatomy questions. I can't remember because I write my quizzes over the summer, but it's fair game if I teach it to you. So yeah, I would, and plus it helps you understand the concepts better.
Okay, I just wanted to know what I should focus on.
Yep, I agree. That's a good question.
Thank you.
Yep. All right, so with all that A&P behind us, let's talk about assessment, because that's really why we're here, right, is to learn how to assess people's cardiac systems. So I think this is going to be familiar to you as far as the layout goes, because Professor Moore teaches assessment the same way I do. But the first thing is we always want to think about how they're presenting with their general health history, right? And there's all kinds of questions you can ask. Now this is, and I hope you're understanding this, when we teach you a system assessment, it's just a focused assessment on just one system. And we would do that if someone came in for that problem, right? So you're not going to ask all these questions if someone comes in complaining about toe pain, right? Like we're going to do this kind of in-depth cardiac assessment if we need to, okay? So if we're really worried about someone's cardiac status, we're going to ask them a lot of these questions. Maybe not all of them, maybe not the way they're worded, but we're going to get the gist of these answers. Like, do you have any chronic illnesses? Diabetes plays havoc on someone's heart and vessels. You'll learn about that in Med-Surg. So we need to know if they have a history of diabetes. If they have renal failure, that will affect their cardiac status. If they have high blood pressure that they know of. So here's the thing, if you just ask them if they have heart problems, they may say no. They may say, nope, I'm good. And then you happen to think, I'm going to ask them this next question. Are you taking any meds? Well, yeah, I take a high blood pressure med. Okay, so how can someone say no, I don't have heart problems, but yes, I'm on a blood pressure med? Can anyone kind of riddle that for me and tell me why someone might think that they don't have heart problems, but they're on a blood pressure med?
I would say maybe because they don't realize that blood pressure has to do with the heart.
Good. There's that. So maybe just they're not educated. Here's the other thing I found when I worked at the ER. You know what? The blood pressure med is working, so they don't see their blood pressure as an issue anymore. Makes sense? Kind of like, do you have problems with pain? No. Are you on any meds? Well, yeah, I'm on morphine every 2 hours. Well, of course you don't have problems with pain right now, but you would if we stopped your morphine. So that's why I always ask about medications. That's more telling than when you ask just about diseases or conditions. You also want to know about over-the-counter drugs because some of them are blood thinners. We want to know about that, like aspirin or even ibuprofen. And some of them are stimulants like cough medicine and Sudafed, and they would make someone's heart race unnecessarily. So over-the-counter drugs are just as important to ask just as important as the prescription medications. Some other questions. This one always blows my mind that I have to tell you this, but you ask, like, do you use cocaine? Like, I wouldn't ask just anybody that. You'd have to kind of have someone who looks like they might actually have a tendency for that. But cocaine, meth, those are stimulants, and they're uppers, and they would cause severe tachycardia, high blood pressure. They could cause a sudden cardiac event like an MI. So we do, if we suspect someone is on these drugs, we do need to ask and hope that they trust us enough to tell us the truth. Here's a hard one too. Do you exercise? Like that one hurts. But we need to know because we need to know their activity tolerance. If they can't tolerate walking up the stairs, that means their cardiac status is pretty poor. So we do need to know how well they tolerate exercise. And then personality types, stress, plays a huge role in cardiac events and cardiac disease. So we need to know if they're under stress and how they're handling it. So if someone tells me they're a nursing student, I'm going to say, ooh, how are you handling that stress? Because we all know that it's there. And if you don't handle it, it's going to take a toll on your heart. How often do you take time to relax? Do you meditate? Do you need sleeping pills at night because you're so wound up? Those are all good questions that we don't necessarily think about when we think about cardiac health. Eating habits, so we know high salt is not good for the heart. We know high fat is not good for the heart. So we just want to make sure we understand what that looks like in their life. Alcoholic beverages, we don't ask that in a judgmental way. We just say, well, how much do you consume? 1 or 2 drinks a day has been shown to not really affect cardiac health, or at least negatively, but excessive alcohol can affect especially their vessels and their coronary arteries. Caffeine is a stimulant, and it could be the cause of palpitations and tachycardias and nervousness. So we do want to know about their caffeine. Most people think caffeine is related to coffee or Coke, but really it could be black tea, not green tea, but black tea. It could be chocolate, like all kinds of stuff can have caffeine in it. And if they come in with a racing heart rate, and if you identify they have high caffeine intake, we've probably fixed the problem. Smoking is huge. You're going to hear smoking kind of bashed on every day because it just affects so many different aspects of our health. But smoking really does affect heart health, and it really messes with the vessels. It makes the arteries really small and tiny, and they don't deliver blood well. So if someone is smoking, the first question I say is, have you ever tried to quit? And why wasn't that successful? And here's another question. Are you open to trying again? If someone says, nope, I'm happy, then I don't try to push it. That's their right. If they say, yeah, I would really love to, but I don't know how, that's when we would do some teaching. Other things in the past you can ask about. When we ask about growing pains, most people don't understand this implication, but 12-year-olds, 13-year-olds, 14-year-olds that are going through growth spurts, everyone has growing pains, but people with cardiac anomalies and defects that they were never identified at birth, sometimes they have worse growing pains in their legs because they don't have good blood flow to their legs. So it's not asking like just general growing pains like everybody, but did you feel like they were worse than what your friends or siblings went through? That might be cause for concern that maybe there's a cardiac defect that was not identified. Recurrent tonsillitis, rheumatic fever. So people who have had lots of strep throat infections and they have not been treated aggressively or right away, immediately, could have valve problems later in life. Strep bacteria has been found to seed in the valves of the heart, and they could cause them to be vegetative and leaky. And so we're very aggressive these days with treating strep throat. You'll notice if you have kids or if you're young, if you go to a doctor and want an antibiotic for an ear infection, they're real hesitant to do that anymore. If you ask for an antibiotic for pink eye, they might be real hesitant to do that anymore. They're trying to stay away from giving too many antibiotics. But if you show up with a positive strep test, they are going to want to treat that aggressively because we know that it can cause not only heart valve damage, but kidney damage as well. You'll find that a bunch of 70, 80, 90-year-old people have valve problems like prolapse or stenosis, and not so much with our generation, because back in the day, those people just lived with their sore throats and didn't get antibiotics for them. So they had lots of valve damage. So that's why we ask about tonsillitis. We ask about fat levels in their blood if they've had those drawn. Of course, any surgeries on their heart or any procedures would be helpful to know kind of what has been going on in the past. Any tests on the heart like EKGs or echoes, that's always good to know too, because if they've had testing, that tells you something has been going on in the past, and that whatever they're complaining about might really not be true, or not true, but new. Sorry, may not be new. And then family history is huge. Heart disease, high blood pressure. Another one that I always asked in the ER, especially with people that are complaining of chest pain, is have you had an immediate family member die suddenly at an early age from a heart attack? There's a lot of evidence out there that says that if someone's immediate family member, like parent or sibling, died before age 50 with a heart attack, that their chances go up exponentially. And so if you know that a patient has that history in their family, we would want to check them and monitor them and manage them much closer than the average bear who may not have that potential for that increased risk. Okay. Questions about history? Just yell, because I can't see anybody but myself right now. Okay. So that was just kind of all general stuff and history stuff. But now let's talk about what if someone comes in with a problem. So they come in complaining of chest pain or shortness of breath or cough, fatigue, fainting, edema, leg pain. All of those things can be cardiac in nature. But here's the thing, you guys, they don't have to be cardiac in nature. Chest pain, if someone tells me they're in chest pain when they walk into the ER suite with me, I can think cardiac, but I can't rule everything else out. It could be they've been coughing and they pulled a muscle, or they've been exercising and that's causing the chest pain, or maybe they broke a rib last week and that's the chest pain. We can't assume that it's myocardial pain, but we can't rule it out either. Shortness of breath, same thing. It could be cardiac. Shortness of breath oftentimes is cardiac in nature, but it could be respiratory. It could be fluid balance. It could be a lot of different things. It could be anxiety. Cough, same thing. Fatigue, same thing. So when they come in talking of these things, we kind of have to drill down and ask good questions to really figure out if it's cardiac in nature or not. So it's called a symptom analysis. We really want to understand the location and what it feels like and when it comes and when it goes and what makes it worse and what makes it better and how long they've been dealing with it. Okay, so a good symptom analysis. Okay, so that's all kind of talking and asking questions. So now let's move into, well, you know what? You probably need a break. You guys need a break? Or are you good? Somebody tell me they need a break and I'll call a break.
Break.
All right. Okay, sounds good. Let's just do like 10 minutes. So let's come back at 2:25. Okay, and then we'll finish up. Thank you. When we're looking at perfusion, one of the first things that we're going to want to look at is pulses. Okay, so I'm going to draw my little guy, Joe. Okay, this is Joe. And so Joe has his heart, right? And his heart will feed blood up to his head, and it'll feed blood to his hands, and it'll feed blood to his organs, and it'll feed blood all the way to his toes, right? That's kind of what the whole deal is. So I have a parrot, so if you hear him screaming, he wants my attention, I'm sorry. So what happens with pulses, and you guys have taken pulses, I think you were even compensated on taking a radial pulse. Let's look at the radial pulse first. You guys know how to find it. It's on this outer aspect where the thumb is between the bones, and you can feel it. Now, one thing we test for with pulses is we want to know the rate, right? How many beats per minute? And you guys know how to do that because you're CNAs. So that's in beats per minute. Well, also while we're feeling it, now the pulse rate, that's only going to be really checked at this radial site just once during your assessment. As I check these different pulse sites, I don't have to count the rate each time. That's not why I'm assessing these. The rate is only usually at the radial site or when you're listening to their heart sounds with your stethoscope, okay? The rate is at the radial, just once. But as you're looking for perfusion and how well blood is getting to these areas, now we're going to look at other aspects of the pulse as well. And one is the rhythm. Okay? And the rhythm can either be regular or irregular. So now that I got the rate and I just checked with the vital signs, now I'm done worrying about the rate. Now I'm going to check to compare sides always, because they should be somewhat similar. So I'm going to feel both. I can't on myself, but if I had someone here, I would check both of their radial pulses for the rhythm. They should be regular. And the best way to describe regular is I tell people you can dance to the rhythm. It's predictable. So you kind of know when the next beat is. So a regular rhythm, pulse rhythm would be lub-dub, 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 lub-dub. You know exactly when the next one should be. That means the rhythm is regular. Okay, it means the conduction system is setting out a very patterned conduction pattern. Okay, now what if you hear lub-dub, 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 lub, lub-dub, lub-dub-dub-dub? You cannot predict that. That would be an irregular rhythm. Okay, so we're going to look for rate, we're going to look for rhythm, and then we're going to look for something called amplitude. And that's really just the strength of the pulse. Okay, and what happens is when you're feeling this pulse, you kind of know what you expect. You expect to find it without much problem, and you expect to feel it without much problem. Okay, I can feel mine, and it's nice and strong. Okay, if it's strong, we have a rating. The rating is +1, +2, and +3. If it's strong and what you would expect, if it's what you think is normal, that is a +2 amplitude of the pulse. So if you feel yours right now, and if you can find it, and it's not hard to find, and you can feel it pretty easily, that's probably a +2 pulse. Now, if you're having a hard time finding it, or it's really, really weak, we would rate it as a +1. And you're going to be able to understand this rating as you assess more and more people with different pulse amplitudes. Now, you've got diminished where you're really hunting around, but you can find it, it's pretty weak. Or you have, oh yeah, that's what I expect. That's a number 2. Number 3 is called bounding. And that means that they have so much fluid on board. Maybe they ate a bag of potato chips last night and chased it with a gallon of water. So they've got all these big arteries and veins, and it's just pounding, and you really feel it just pounding, 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 much stronger than you would anticipate. That would be considered a +3 pulse. Okay. So this is when you can feel pulses. You can use this amplitude and this rhythm for any of the pulses. So you can use it for radial. You can use it for carotids in the neck. Now, do not test both carotids at once, because you will make them pass out, and you'd probably have to buy them a fruit basket after they come to and they sue the hospital where you're working. So don't check both carotids at once, but you can check one and then compare it to what you feel on the other. You can also do femoral pulses. You can look for the rhythm and the amplitude there. You can do popliteal, which is behind the knee pit. I can never find those, so I don't really look for them. Okay, so there's lots and lots of pulses. There's also pedal pulses, which are in the feet, and there's 2 of them that we'll talk about in a little bit. But all of these, we need to assess the rhythm and the amplitude. Okay, now, if someone's thinking ahead, they're saying, well, what if I can't feel it? What if I can't feel this radial pulse or this popliteal pulse? What do I put? You don't put 0. 0 is not a choice. Okay, if you don't feel it, you can either put not palpable, which means you can't feel it. Okay, or you can use absent, but the only time you can say a pulse is absent is if you use a Doppler device and you still can't hear it. If you remember, a Doppler is a little tool that you can use to hear heart rates, and it sounds like whoosh, whoosh, whoosh. They use them in maternal fetal doctor's offices all the time. You can actually use that on a pulse site and hear the whoosh, whoosh, whoosh. So if I can't feel it and I have a Doppler and I listen and I can't hear it, then I can say absent. Okay? I can say not palpable if I just don't feel it, but I don't have a Doppler. Does that make sense? Okay. So upper extremity perfusion, arm perfusion, we really base it a lot on the radial pulse, okay, and see how strong it is. We also want to look at lower extremity perfusion, and that's when we look at our pedal pulses. Our pedal pulses, there's two sites that we use. One is the dorsalis pedis, and one is the posterior tibial, whoops, like tibial, like the bone, okay? And behind the bone is what that means. So where is the dorsalis pedis? Well, if this is this guy's foot sideways, the dorsalis pedis is on the top of the foot. So if this is a foot, I can't get my foot on the on the desk, but if this is my big toe, okay, it's going to be up in here. Okay, so I would look between my big toe and my first toe, like my normal toe, and go back into the fleshy area between the bones, and you should be able to feel a pulse in there somewhere. Now that takes practice, so don't freak out if you can't find it today. We'll help you when we're in the lab together, but we want you to at least try. So between the big toe and the second toe, back in the fleshy area between the bones, you should be able to feel a pulse. Okay, sometimes you have to push harder, sometimes you have to push softer, but you can usually find a pulse in there on the top of the foot. Now, that delivers maybe 20% of the blood to the foot. The better pulse to assess is the posterior tibial, okay? So if I'm looking at the side of the foot, okay, and that's a bad example of a foot. It looks more like a shoe. But if this is the inner aspect, so that this is the big toe side, there's going to be a bone back here, right? So feel down your leg and see that big bone that's sticking out. It's on the inside of your ankle. You'll notice there's a cavity behind there. If you run your fingers behind that bone and push, you can feel that posterior tibial pulse back there. It takes practice, so don't get frustrated. That delivers 60 to 80% of the blood to your foot. So you really need to make sure that we can find that one, okay? So dorsalis pedis is on the top, posterior tib is on the inner aspect behind that ankle bone, okay? All of those, you can check all of them for these things, but really upper extremity, you're gonna check radials. For lower extremity, you're just gonna check the two pedals, and you check them bilaterally, right? So I'll have my hand on both of their feet at the same time and feeling for the rhythm and the amplitude, okay? So those are pedal pulses. Questions on that? Okay. Another thing that we check for, so that was pulses. Another thing we're gonna check for is capillary refill. Now, capillary refill means how quickly does blood get into the tissue. So the best way to do that, and we do that upper and lower. In the upper, we typically look at a finger. We will squeeze it until it blanches and gets all the blood out, and you'll see it turns white. And then did you see it pink back up? This is good capillary refill. Capillary refill should not take more than 2 seconds to refill. So I count 1, 2, yep, it was healthy. It pinked up in 2 seconds. Anything longer than 2 seconds means there's poor circulation to that area, okay? So capillary refill, normal is less than 3 seconds. So 1 to 2 seconds is healthy. We can check that anywhere. If I'm worried about frostbite on my nose, I can push and make the blood go out and see how fast it comes back in. Or my arm, I can see if there's good perfusion to my arm. We also will check the toes, okay, for the same thing to make sure that there's good refill when we squeeze the blood out, okay? And the healthy finding is 1 to 2 seconds. Questions on that?
Professor Punky, can you repeat what capillary refill means?
Yeah, I don't know what the textbook would say word for word, but it is when you squeeze out all the blood out of the tissue and you count to see how long it takes to pink back up and fill back in. So it takes, how long does it take for the capillaries to fill back to refill? That's what that means. Can you see my video?
Yes.
Okay, because I can see where I'm getting it really white. And then as I count 1, 2, it's pink again. So that's healthy. Some people start out white and pale, so they have no capillary refill. It never refills because it never was full in the first place. But healthy cap refill goes from white to pink, back to pink in 2 seconds or less. Okay. Can you see how both of these things can tell you a lot about perfusion, how well the blood's getting to this tissue? If they've got good pulses, you know it's being delivered there with some velocity. If they got good cap refill, it means the tissue gets good, a good feeding or perfusion of the blood. Okay, let's see what else I'm missing. Color. So if the color is pink, you know there's blood there. If it's pale, you know that it's lacking blood. Okay. Temperature. If it's cool, it means there's a lack of blood. If it's warm, there's more blood. So some of this is pretty commonsensical. Let's talk about the angle of the nail bed, because this is something with respiratory. I don't know, did Professor Moore talk about clubbing at all?
Yeah.
Okay, so you know that I don't have clubbing because look, you can see the guy right through my fingers. If I had clubbing, these things would be so rounded that they would touch, okay? And clubbing is a sign, a long, late sign of chronic hypoxia. So this isn't something that happens because you have a cold or you have pneumonia that resolves in a week. This is something where you have maybe COPD or cardiac failure and you just don't get blood to your fingers and oxygen to your fingers for months or years. The tissue actually morphs and changes. Okay, so that's what clubbing is. And that's why we look for it with cardiac, because maybe it's a pump problem. Maybe that's why there's hypoxia in those nails. Okay. That's all upper extremity. I already told you about all of this. Edema is another thing we want to look at. Edema is pretty much just swelling. And so if you notice that there's swelling in ankles or hands or around the eyes, you'll want to kind of push lightly. And if it makes a dent, that's considered pitting because it makes a pit. Okay, we'll talk a lot more about edema in later weeks. But for now, just if there's swelling, we want you to say that it's present, or if there's no swelling, that edema is not present. Okay. Apical pulse, you already did a skill for that, right? And so you know how to find the apical pulse. Can someone tell me the things that you chart about an apical pulse? What are you looking for when you're listening to an apical pulse?
Irregularities.
Good, 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 good. Those are both good answers. So irregularities and a lub-dub. So an apical pulse, we're going to do the rate, right, for a minute. Always a minute, never less. We're going to make sure that it has a good rhythm, what's the acceptable rhythm? Regular, right? That's what we're looking for. And then we're going to look for those heart sounds, the S1 and the S2. The S1 is actually the lub that you hear, and the S2 is the dub that you hear. Okay, so if I hear lub dub, lub dub, lub dub, lub dub, that means they have a good S1, S2. Okay, what you might hear sometime is lub dub dub, lub dub dub, right? And it's not the just S1 and S2, but it has other noises and other sounds. So that is not good heart sounds. So what I want you to chart for an apical pulse would be like apical pulse, 78 beats per minute, S1, S2 present, and regular. That would be like the perfect healthy heart right there. Okay. Questions? Okay, let's go back. Now, after you check all of this, you have to document it. So I've got Oh, and then Professor Moore already told you about bruits. That also applies here because a bruit is in the aorta, which is part of the cardiovascular system. So if you hear a swooshing in that area, you know that there's a weakened pouch and that we need to report that immediately. Okay, so that's another thing that you can include either in your abdominal assessment data or in your cardiovascular assessment data. It kind of goes in both or either. So documentation is just all the things we talked about. Vital signs, skin color, peripheral pulses, upper and lower extremity, capillary refill, upper and lower extremity, if there's clubbing present or not, if there's edema present or not. Let's talk about hair distribution for a minute because it's a really good indicator of cardiovascular health. So the heart pumps blood down to the toes and it carries oxygen, but it carries so much more than just oxygen. It carries protein, it carries vitamins, it carries minerals. So if blood is not getting down here, these legs on this guy are not going to be able to grow hair. Okay, so we assess for hair growth on our patient's legs. Now, if someone's shaving, then we know they have hair growth, right? But if someone has shiny, hairless legs without shaving, that means they have some problem with their peripheral circulation. Okay, so we would report or document hair growth as present or even, depending on how you want to word it. Okay, so lower extremity hair growth present is usually what I would write. And then sometimes you want to mention lung sounds, especially if they're abnormal, like crackles, because crackles oftentimes is because of a heart problem. Okay, whew, we learned a lot. Here's my sample documentation, but I don't want you just to copy mine. But what I wrote was a 42-year-old male sitting in a relaxed position with easy respirations. That paints a good picture right there. Blood pressure is normal. Extremities are symmetrical, so they're both getting the same amount of blood flow and food. Skin is intact, elastic turgor. Skin is pink and warm. Apical pulse is 72, S1 and S2, regular. Radial pulses are +2 bilaterally. Upper extremity capillary refill is 2 seconds bilaterally. No clubbing present. Then you go down to the lower extremities and you do the same thing. Pedal pulses, capillary refill, edema. Okay, I see a hand. Eden.
So,
Or no, or Elizabeth, I can't read.
sorry, it's Eden. I don't know why it says Elizabeth, it's Eden, but
Okay.
for the rubric, it says like put the name and their initials in the documentation. I guess like when you gave your examples, I didn't put that in there. Like, where would you put that in, like the very beginning?
Yeah, so I would say, like, if you were writing on me, TP, comma, a 40-something-year-old, actually 50-something-year-old female, right? So you just put it right at the beginning. TP or DM, whatever their initials are, can be right up front. Yep.
Okay, so you don't have to put their full name either.
No, we don't want you to put full name because of HIPAA.
Okay.
You might when you're really working and taking care of a patient in a real chart, but for our purposes, especially with each other, we will just use initials.
Okay, thank you.
Yep, good question. But this is just kind of, you know, everyone's going to write differently. Everyone has their own style of writing. This is my style of writing, but to copy it isn't going to help you. You kind of have to figure out your own style of writing. Questions? Whew. Whew. Okay, so why don't we take a break, come back as soon as you want, or can. I guess want is probably not the right word. And I'll put you into your own rooms for some privacy, and you'll start your cardiac assessment on your patient. I know a few of you don't have patients. You can actually do a pretty good cardiac assessment just on yourself. So you can do that. And then when you're done, come back to the main session to do your documentation. And I'm hoping to get you out of here early. So, you know, chat box me from your private room if you need my help. Call me in, and I'm going to be bopping in and out just to check on everybody and answer questions. Okay? Speak now if you have a question. So what we're going to need then is you bring this with you to clinical, just have it in your folder, the write-up, and then Professor Moore will collect it at some point, probably Thursday, probably tomorrow. I'm not sure though, so just hang on to it until she asks for it, okay? I'm going to put you in your own rooms. All right. I will jump in and out to check on you. Otherwise, just send me a message if you need me. And then when you're done with the actual assessment, come back to this room so I can see who's completing and who's on time. Okay? All right. See you in a little bit.